So today we'll discuss Obamacare, and I'm honored to have with me today Dr. Stephen DeAngeles. Dr. DeAngeles is a well-respected and compassionate physician, board certified in internal medicine. Dr. DeAngeles is a clinical instructor of medicine at Northwestern University's Feinberg School of Medicine. He has been voted top doctor, and I know firsthand that he is one of the finest diagnosticians I've ever met. He was born to be a physician. Am I forgetting anything, Steve?
No, you made me sound better than I am. Thank you.
I don't think so. Welcome. Thank you for agreeing to discuss Obamacare. Obamacare, although presented with good intentions by former President Barack Obama, is viewed by many as a blemish on his presidency. Obamacare was a battle cry for the Republicans during the recent presidential election, and newly elected President Trump promised during his campaign to replace Obamacare. He now states it's easier said than done. Most Americans, including myself, don't understand it. So first, I'd like for you to explain healthcare delivery in this country prior to Obamacare.
So prior to Obamacare, the whole system was geared up to fail as well. And one of the major reasons was there is no cost control in the system. When insurance for medical care began, there was really only two insurance companies in Illinois, for example. They were allowed to spread their risk among a large population of people, which most people being healthy were able to keep their cost then lower. As the proliferation of the insurance industry occurred, you then had multiple insurers vying for the same population of people, and this then created, people would think it would create competition, but in fact what it did is it elevated the prices and ultimately the cost of health care. Hospitals no longer had any true accountability for raising their rates, and insurance companies tried to get to the hospitals that had certain reputations. So that, along with Medicare, drove the cost of health care up, really beginning in the mid-'80s.
And how were the uninsured cared for before
Prior to-
Obamacare? Yeah.
So predominantly it was, Medicaid and, hospitals. And this is kind of my pet peeve because hospitals are nonprofit organizations. And in Chicago, for example, each of the hospitals that are nonprofits don't pay any federal tax. They don't pay any Illinois tax. They don't pay their water bill. And once you had Medicare and Medicaid, the need for really a true nonprofit hospital fell off because most people then would be covered by those two. The truly indigent population in Cook County, for example, should be able to go to any hospital that they want because those hospitals are getting gigantic breaks from the government, but they end up shuttling them to Cook County Hospital. So prior to Obamacare, there was a lot of indigent patients that had no insurance at all, but they were able to get care by, either going to Cook County or showing up in emergency rooms throughout the country. And they would get adequate care. They just didn't really have access to primary care unless they paid out of their pocket. But a lot of doctors, including myself, also gave a lot of free care to patients who couldn't afford it. The problem for the patients who had no insurance and couldn't afford it, hospitals often wouldn't, just totally write off the cost unless they were truly, homeless or indigent where they couldn't get the money from it. I could give you an example of a patient I had several years ago, prior to Obamacare, that was hospitalized. She had no insurance. She was in the intensive care unit for a couple of weeks. I wrote my bill off. I called Northwestern and asked them if they would write their bill off. And they said, well, they can write 10% of it off. And the patient ended up basically having to pay a second mortgage over a 10 to 15-year period of time until their bill was, cleared.
Oh, my goodness. Yeah, you hear about that all the time.
Right. So the truth of the matter is, before Obamacare, the insurance industry was a disaster. And the healthcare something had to happen in healthcare.
So how is Obamacare different? How did it come in as the savior?
Yeah, so the argument with Obamacare, and it is very complex. I can't say that I'm an expert in any way, but basically the healthcare exchanges allowed everybody theoretically to get an insurance policy that they would be able to afford and that they would be able to choose. The problem is, so when they were able to get a healthcare policy, if you had made less than a certain amount of money, you would get subsidized by the government so that you were able to have that insurance. And to Obama's credit, believe it or not, and to the Congress's credit, you needed to have a mandate. You really need everybody in the area needs to have insurance so that the healthy people can kind of offset the cost of the sicker patients. But by having that mandate and then saying that even people with pre-existing conditions need to have insurance, those are great things. But what happens in reality is the younger, healthier patients are starting to say, well, you know what, I'm not going to pay anything. If they catch me, I have to pay a fine of $695 or whatever it is, and I'll wait until I get sick. And then when I get sick, they have to take me. They can't reject me. So what you're seeing, at least in Illinois, is a lot of people aren't signing up. They're not paying anything. Then they get diagnosed with something. Now they say, okay, I want insurance. And that just is a death knell to any system.
Oh my God, definitely. And then what about crossing state lines? I hear stories that you can't, if you have Obamacare in California, at least, there's people that say, oh, wait a minute, if I travel to blah, 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 I'm not covered. Is that true?
I don't think so. Again, I'm not an expert on it. I think that once you have insurance, you can travel everywhere and you're covered. So, that's my understanding of it. If I have insurance wherever I go in the world, my insurance is responsible for paying that.
Okay, so that's just one of those,
Yeah, well, it might be, the nuances may be the insurance company may say, well, yeah, we're going to pay, but it's out of network. But
okay.
I think for emergencies, they have to pay, in-network kind of costs no matter where you are.
Okay. And then what about choice? Because that's another thing that I hear. Well, patients will say, well, I'm not allowed to go to this particular center they're telling me that I have to go to this hospital.
No, that's true. So, people really have lost their choice. And as the insurance companies are getting, what happened is a few years ago, and I don't exactly know how that happened in Congress, but Obamacare originally was built that if the insurance companies lost money, the federal government would support, a certain portion of their loss. Congress took that out 2 years ago, I think. So now the insurance companies were just taking a beating because people would wait until they got sick. I don't want insurance now. I'm not paying my premiums. I get sick. Now all of a sudden I call up and I get on the healthcare exchange and I say I want insurance, and the insurance company can't deny me. And now I have, some illness that's going to, run thousands of dollars. So the insurance companies, started losing significant amount of money. So then they go back and they're going to say, well, we can't pay for, Northwestern or Rush or University of Chicago or North Shore University healthcare systems because they're too expensive. So if DeAngeles, if you want to sign up through, healthcare.gov, your network hospitals will be, X, Y, and Z, and your physicians will be such and such. So that's where you really lost your choice.
Mm-hmm.
So if you want your doctor, if you like your doctor, you can keep your doctor. That didn't pan out.
And so it's like the way I see it is that, the good news is that you have insurance. The bad news is you have no choice, and you may end up at an inferior hospital with inferior care, which will affect your outcome.
Right. And the other part of that too is so not only will you don't get your choice, but the deductibles have gone so high, it's effectively saying you really don't have insurance unless it's some catastrophe, because all these patients that, couldn't afford insurance in the first place, now all of a sudden they get a plan that doesn't allow them to choose the hospitals or the doctors they want because they're out of network, and also has a high deductible. So they're not going to, if your deductible is $10,000 and you're making $30,000 a year, I'm not going to go to my primary care doctor and get preventative care because I don't want to pay anything. It's just basically having a catastrophic insurance policy. So you lose your choice. You really don't have health care. You have catastrophic insurance.
Oh my gosh. And I was just with a Lyft driver last week who said, that he bought it last year and now this year it's gone up, and he just said, I don't know how I'm going to be able to do this if this keeps
the
increasing.
Premiums have gone up exponentially because the insurance companies are losing money because they have to take everybody, and the only people that are signing up are the ones that are sick and using it.
And the man on the street said, well, this is what I've heard, is that the only winners are really the insurance companies. Doctors have lost out, patients have lost out, but insurance companies and maybe some of these institutions.
Yeah, insurance companies never lose, and the big hospitals don't lose. What the hospitals have done, which is nefarious in my mind as well, is they've had facilities charges. So, the AHA has a great lobbying group. So when they were lobbying in the Obamacare and with the insurance industry, they're able to keep the facilities charges up high, and they ultimately don't care about what the physicians, individual physicians are making. So, and then the hospitals buy the physicians groups, and the physician basically becomes a loss leader for the hospital, and their facilities charges are high, and they make, significant profits on that. And then Candy kept me going, but then they end up paying their, hospital administrators exorbitant amounts. Compare what hospital administrators were making 25 years ago to what they were making now, and it's ridiculous.
Oh, it's sinful. It's like,
It is sinful. So,
yeah, it's, I remember, I mean, years ago when I started out my career in nursing, hospitals were run by physicians. And then all of a sudden, you're getting your MBA in hospital administration and you want a salary that's equal to what the CEO of General Motors is getting.
Exactly. And the difference between General Motors and a hospital is one's a for-profit, the other's a non-profit.
That's exactly right.
Your listeners should look into what hospital administrators make, and that, that's also one of the problems with the whole system. Hospital administrators are making, 100 times what the average hospital employee is making, if not more.
Right. And
when you and I started, they were making, maybe twice, 3 times, 4 times. They were making, equal with what an average doctor was making. Now there's no doctors that make what the hospital administrators make at these big hospitals.
It's true. It's disgusting. And so then when you break it down and you say, okay, well, how much do you have to charge a patient to be in a bed in a private or semi-private room? How much do you have to charge for procedures? And the list goes on in order to pay a salary like that. And it's not just the CEO of the hospital, but it's the vice presidents and all that are making these unbelievable salaries.
Right. No, that's exactly true.
And, I wanted to just circle back to what you were talking about before about, penalties, paying penalties, and that, young people are willing to accept the penalty. I have to tell you that last year was the first time Steve and I had to show proof of insurance when filing our tax return. I couldn't believe it.
Right.
And I thought that when you were a taxpayer, that you were entitled to go to a county hospital if that's what you want to do.
Right, because you're paying taxes. And but my argument, though, Candy, is that there shouldn't really be the need for any county hospitals, because the only reason the county hospitals developed initially was long before Medicare, which was in 1935. So once Medicare and Medicaid came in, prior to those years, there was no coverage for the older people or for the poor people, so hospitals had the argument that they were truly giving charitable care. Now that argument is out the window, because Medicare is covering most of the patients, with disabilities or patients, that are older, et cetera, et cetera. So, and then the hospitals are even gaming the system more, because what they do is they say, okay, well, Medicare pays us, but it really costs us, $10 to give this care, and Medicare's only paying us $5. But it costs them $10 because they overcharge for the MRI, they overcharge for the aspirin, they overcharge for the Tylenol. Oh, so it's more expensive to pay, and then they get their Medicare fees boosted for the facility. It's a nefarious, complex plot that won't be fixed until, somebody really starts to, hammer the American Hospital Association and their administrators.
Well, you bring that up. It's how do you keep the patients, the physicians, and the insurance companies content, happy? And what would you say to President Trump? I mean, as far as Obamacare, what's the solution?
The problem with it, too, is it's so complex, so the average person, including me, you really can't understand all the different insurance plans in this area. And there's so much complexity to it that's in their favor, because the insurance companies are playing that game and the hospitals are playing that game, but the average patient, the average physician, there's no way we could really truly understand it. So my thought would be when you build a highway, you put out the bid to 15 construction companies. You don't have each construction company take a mile. Whoever wins the bid builds that highway. So my thought would be is you have the insurance companies bid on geographic region. Whoever wins the bid provides insurance for that geographic region for a set price for a set period of time. And the way that would control costs is a couple of reasons. The insurance company would say, okay, we're going to pay for this geographic region. The usual and customary fee for an MRI is $1,000. So Steve DeAngeles signs up for the insurance company, and it could be indemnity plans, HMOs, PPOs, POSs, point of services, whatever you want. So you'd have the whole spectrum of plans you could sign up for the company that won the bid. They pay a usual and customary fee. In that area is $1,000. So they give me, Steve DeAngeles is going to get an MRI. Here's $1,000, Steve. If Northwestern's charging $4,000 and Rush is charging $1,200, I'll choose to go to Rush and pay the extra $200. The machines are comparable and the radiologists are equally as good. So I go to Rush and I get my MRI. What that would do is it would force Northwestern eventually, with the free market, it would force Northwestern to lower their fees, or they would be getting no patients, or they'd be getting just a handful of the super rich patients that want to throw the $3,000 out the window. The company who wins the bid for the geographic region would have to provide insurance for everybody in that geographic region, no matter what the pre-existing conditions were. People would be required to sign up, just like you're required to sign up for car insurance. And I don't know what the penalty would be if they didn't, or you could have them maybe retroactively pay if they come into the system, with an illness and they hadn't paid for the past 3 years when they were, mandated to pay. But, you can work on that. Doctors would also be paid a usual and customary fee. So the doctor, if my office visit's $200 and the usual and customary is $100, the patient would have to decide whether I'm worth it to pay the extra $100. On
Mm-hmm.
top of that, you could have a board in that geographic region made up of hospital people, patients, physicians, and insurance companies. So a board of 10 or 15 people, and they would oversee the whole system. So you'd have the demographic data, you'd have the health data on all the patients and on the doctors. So if Steve DeAngeles is a bad doctor and ordering, MRIs on everybody, and Terry Sullivan, my partner, has the same patient populations but only ordering, 2 MRIs a year, the insurance company could tell the board, and the board says, DeAngeles, can you justify ordering all these MRIs? And if I say yes, here's why. Okay, we're sorry. Or no, I just like to order them. Well, you can't do that anymore. So you would have
Uh-huh.
a way to police the physicians. You'd have a way to control the cost, and patients would like it better because now somebody else is watching the insurance company, so they can't cheat me
Mm-hmm.
because I can't figure it out now.
No, it's true. I'm so confused by it all.
And everybody is, and they want to keep it confusing. The more confusing it is, the more that they could profit from the system, because then that's their game. So there's
Yeah,
no way you and I could play against them.
yeah, exactly. I've heard, others speak about having just one universal plan, and then if you want to buy these, extras, you want to buy the dental, you want to buy the, eye care, whatever, you can tack that on for an extra cost. But I'd also like to talk to you about the patient's responsibility. It just seems like our population here is getting fatter, sicker, putting a tremendous financial burden on the
Right.
healthcare system. What do you say to that?
Well, because again, it's, people, if you're not paying for something, you have no incentive to try to control the cost. That's why if you had it where it was just paying the usual and customary, and I would have to do a little shopping, or I'm going to have to pay the additional cost. Patients have to have some responsibility, for their own health care, ultimately. I mean, so if a patient, isn't taking care of themselves, or if they're spending money because they just want tests done, well, then they're going to have to pay a certain portion of it. And that's why my system, the single payer system per geographic region, keeping capitalism involved because it's all private insurance companies,
Mm-hmm.
would work. Because now the usual and customary is $1,000. DeAngeles, go somewhere where it's 1,200. If you choose to go to somewhere where it's 4,000, it's that's your responsibility. So that you have to put a little bit of responsibility back on the patient when it comes to paying. But the patients can't understand the insurance companies. So this would allow them to understand. Most people could understand that and say, okay, yeah, I'll go to the cheaper place for an
Mm-hmm.
MRI. That's equally as good.
Right. And they're being empowered as the consumer.
Because if people don't pay for something, you ultimately, I mean, and that's just human nature. I mean, it's everything. If I'm not paying for it, okay, I don't care what it costs. 4,000, the insurance company's going to pay, 90% of it, and I only had my deductibles met, so it doesn't matter to me.
Mm-hmm. Well, I have to tell you, I remember talking to you about this years ago, and I just thought that your idea was a win-win across the board. I always thought it was brilliant.
Well, thank you. No, thank you. And it's funny is I was just talking to somebody here in Illinois who's a politician, and I was telling them, and he wanted me to write it up and kind of get it back to them. I've written about it years ago, but I think it's the only system, and you could either divide Illinois into 3 regions, or you can have geographic regions in Northeast, Southwest, Northwest, and have, as long as you had the board that would oversee it, physicians and hospitals and insurance companies, and people would understand it. And you have a single payer system per geographic region, because the United States is too big and too heterogeneous to have a single payer system for the entire United States. But if you divided it into regions, it would work.
Yeah. Oh my God. Well, I'm going to have to tweet Trump. What do you think?
Yeah,
About you?
get him to do it.
No,
You could whip him.
you're going to have to take a sabbatical and go to D.C.
Yeah, you could whip him.
So before we end, do you have anything that you'd like to add, or any advice to patients or their?
I mean, yeah, the advice to the patient would be is to make sure you take care of your health, make sure you see your doctor, and worry about payment secondarily. I mean, a lot of people now I know aren't going to physicians. They're waiting until it becomes catastrophic, or they're just hurting, ultimately shortening their lives and their quality of lives. I think, and I don't know the data exactly, but people aren't taking their blood pressure pills because it's getting so complex, and hypertension, we're losing our hypertensive control that we made such big gains in. Diabetics are tending to do a little bit worse, in the general population, not in elite populations.
Mm-hmm.
So my advice to patients is take care of your health, first and foremost, and let the system kind of sort through it. Don't put something off because you don't understand it.
Well said. Well, you know what, Steve, you're the greatest, and I thank you
You're the
so
greatest,
much
Candy.
for being a guest on Self Help
Well, thank you.
101
Well,
and for
thanks. You're the best.
explaining this. I learned a lot. Thank you.
Well, thank you. I'll talk to you later.
Okay, great. Bye-bye.
Bye-bye.
Join me next time for more of Self Help 101.